Good afternoon, everyone. Sorry for the little delay. Welcome to CanVector National Thrombosis Seminars. It is my pleasure to host the first session of 2022. These are monthly seminars that are hosted live throughout the academic year. And all the presentations are video recordings, and it will be made available online at www.canvector.ca. The CanVector National Thrombosis Seminars are self-approved group learning activities. The planning committee is as followed, and it is chaired by Dr. Maral Koulian. Today, we will have a hot topic on subsegmental pulmonary embolism with two outstanding speakers. Dr. Marc Carrier is head of the Division of Hematology in the Department of Medicine at the Ottawa Hospital. He's a professor in the Faculty of Medicine, University of Ottawa, and a senior scientist in the Clinical Epidemiology program of the OHRI. He holds a Tier 1 research chair in venous thromboembolism and cancer from the University of Ottawa, and a new investigator award from the Heart and Stroke Foundation of Canada. Dr. Grégoire Legal is a professor in the Division of Hematology of the Department of Medicine at the University of Ottawa. He is a physician in the Thrombosis Program, Division of Hematology, and a senior scientist in the Ottawa Hospital Research Institutes. He holds a Tier 1 research chair on diagnosis of venous thromboembolism. Dr. Carrier and Legal will tell us on their long journey in the subsegmental underworld of pulmonary embolism. After their presentation, there will be a 15-minute question and answer session. I'm excited to listen to the presentations.
Good afternoon, everybody. It's Marc and Grégoire from Ottawa, and we're quite excited to have a discussion today about our long journey in the subsegmental underworld of pulmonary embolism. You may be wondering why we don't have any hair left, and it's probably the SSPE is the main contributor to hair loss and weight gain over the past 10 years. And we just wanted to show you and provide you with some insight on how to start and conduct and finish a study. And sometimes it takes longer than expected. This particular one took us 10 years, but hopefully it's providing clinician with a little bit of insight on how to manage these patients and actually probably highlighting more important knowledge gaps that need to be fulfilled by someone else, because we're done in that field. But before starting, it's always important to have a look at potential conflicts of interests of the speakers. These are mine, and these are conflicts from Grégoire. And what we want to do over the next 40 minutes or so is really trying to provide you, we need to go back in time and having a discussion about the rationale for the SSPE study. So we're back in 2010, and we're seeing PE being overdiagnosed. And, you know, are these clinically important or not? Do they need to be treated or not? And how can we best manage these patients, making sure they don't have any recurrence, but also making sure they don't have any bleeding complications. And then we'll review some diagnostic challenges and current clinical practice guidelines, because that has changed during the conduct of the SSPE study, despite really no data to support that, which led us to a little bit of a delay in recruiting. We'll touch base on that. Grégoire will discuss the methods and the results of the SSPE study, and then we'll finish off by discussing implementation for clinical practice. Where's the field now and where it should go, and what's ongoing for clinical trials in that particular field. And just to highlight very briefly, we have a short case that we see not infrequently in our thrombosis clinic or as part of your clinical practice. A 51-year-old woman, not really with any significant comorbidities, presents to the emergency room with shortness of breath, pleuritic chest pain, suspected PE, likely pretest probability based on a Wells model. A little bit of blood work is done, and then she's sent for diagnostic imaging. And you can see here that the CTPA shows a single subsegmental filling defect without any involvement in more proximal pulmonary arteries. And it begs the question, or at least when we started this study, does this clot need to be treated or not? And the options have changed too. And that's important to keep that in mind when we do the risk-benefit ratio, because when we started the study, it was this patient's on low-grade heparin and warfarin, or we decided not to treat these patients. Now, option number 2, the direct anticoagulants are available and they need to be incorporated in decision-making. The other thing that we could discuss is, or we'll try to highlight is, should this patient receive no or conservative management, no anticoagulation without any further investigation? Or should we try to find out if there's concomitant lower limb proximal deep vein thrombosis, and if so, then consider anticoagulation, of course, and without that, then maybe conservative management is reasonable too. So let's start with the statement of the clinical problem and the incidence of SSP. And again, this is a travel back in time a little bit, just trying to understand the problem, or what we felt was the problem at the time. Because the reason why we do VTE for a living, and reason why we have a Canadian network for clinical research, is P is a common disease and it's associated with significant morbidity and mortality, and that's why we see patients urgently in the emergency room. We often start anticoagulation before ruling in or ruling out the diagnosis. And for decades, clinicians have been taught that an untreated PE is associated with a high morbidity and high risk of morbidity for patients because of the underlying risk of recurrent event. And over the past 20 years or so, how we make a diagnosis of PE has changed significantly. We used to use a lot of ventilation perfusion scan, and over the past 15 years, 20 years or so, CTPA is becoming more readily available. It's in all the emergency room. It's relatively easy to get. It provides a clinician with an alternative diagnosis. It has a higher sensitivity for smaller vessel, and therefore it really took the place of VQ scan for diagnosing or ruling out PEs, which is good. But as I mentioned, it's also associated with higher sensitivity for smaller vessels. And then when we started practice, single detector CTPAs were now becoming out of fashion, and multi-detector CTPAs were available. And at the Ottawa Hospital, we had a 4-detector CTPA, which, as you can see, showed thickness of the slide of 1 millimeters, acquisition time of 25 seconds. So really putting a lot more emphasis on the sensitivity of the smaller caliber vessels. But just over a sparse of over a few years, it went from 4 to 16 to 64. Now we have all the CTPAs, or all the CT scans, have over 300 detectors with slightly thinner thickness of the slides and acquisition time that is smaller, again, improving sensitivity for these smaller vessels, but also maybe trying to, or picking up things now that is unclear if it's clinically significant or not. They're so small. So we were seeing a big difference. And this is a landmark study that was published in the archives back in 2011 when we were planning the SSP study. And you can see on this graph here, looking at the incidence of PE diagnosis in the US. And the dotted line is really where multi-detector CTPA became available for clinicians in clinical practice. And you can see with the purple and blue lines that the incidence of PE after the establishment of multi-detector CTPA in clinical practice has really increased over time. And after 1998, there is really no difference in overall mortality. So as a clinician, for you and I, we beg the question, we're happy to have more business, more PEs, but it also led to some questions. So are we seeing a true incidence in PE diagnosis? Is CTPA more sensitive compared to VQ scan, for example? Or are we actually starting to overdiagnose PE in clinical practice? And let's look at these 3 different items individually and try to figure out if there was clues from that study that can help us decide if what's the underlying reason why we saw an increase in the incidence. So if you have a true increase in the incidence of PE diagnosis, you'd have an increase in the risk factors leading to more PEs. And that could make sense because we have more cancer, for example, cancer patients are living longer, and therefore that could lead to an increase in the incidence of PEs. But we shouldn't see any differences in the disease severity, meaning that if there's more clots, there's more clots of all different sizes. And if that is the case, so if it's a true increase in the incidence, then obviously you'd have an increase in the incidence as discussed. You'd also have an increase in the mortality rate when you're comparing fatal PE over the general population. And you shouldn't really see any difference in the case fatality rate, which, as you can probably remember, is looking at the rate of fatal PEs over a total number of PEs diagnosed. If CTPA would be a more sensitive test, then again, you'd have more PE diagnosis, but you would find fewer deaths related to it because you would think, well, we're picking up clots before they get worse. We're starting anticoagulation beforehand, and therefore we should see a difference in the overall mortality. So if it's a more effective test, we would have an increased incidence, but the mortality rate should decrease. And the case fatality rate should decrease over time too, because we're picking up these clots sooner and intervening on them sooner. And what about overdiagnosis? Well, again, there's an increase in the incidence, but the number of cases that we're treating may not benefit from treatment because it's not changing the natural history of the disease. And therefore, if that is the case, then we would see an increase in the incidence, no changes in the mortality rate, and a decrease in the case fatality rate because there's a whole lot of PE diagnosis, but very few fatal ones. So we would expect a lowering of the case fatality rate. And if we go back to the study I've shown you, following the 1998 cutoff where multi-row detector CTPAs became available, we can see that there's a substantial increase in the risk of having a PE diagnosis. There is no difference in PE mortality or overall mortality, and we saw a decrease in the case fatality rate by about 40%. Keep in mind that back then too, the only anticoagulant that we really readily had for management of VTE was warfarin, and therefore during the same time when they looked at potential complications from anticoagulation therapy for these PEs, so major bleeding, there is a significant increase in the risk of hemorrhagic complication. That's also important to keep in mind. So if we again summarize what we saw from that particular study, or what we understood from that study, we said, well, there's an increase in the incidence, no change in mortality since 1998, and a significant decrease in case fatality. Maybe we're starting to seeing overdiagnosis of these clots, and maybe we need to be mindful of that as clinician. Now, we didn't base the whole SSP study just on one thing. There's other clues in the literature, and Dr. Deluc, the moderator and CanVector member, also did a study when he was based in France. And what he did is, as you can see, he looked at the observed cases of all VTEs, DVTs, and PEs and isolated PEs in 1998, and then looked at the observed case in 2003 and compared that to the expected cases. And as you know, VTE has become more popular, there's more awareness, more thromboprophylaxis over time. So you would see that there's a decrease in the observed versus expected for all cases and DVT cases, but there's an increase for all PEs and isolated PEs, so PEs without deep vein thrombosis. So it begs the question, what has changed between 1998 and 2013 in Brest, France? Well, back in 1998, 4.4% of PE cases were diagnosed using CTPA, and that increased to 73.7% in 2013, and therefore maybe again leading to data suggesting that we're over-diagnosing. Now, there is other clues in the literature, and David Anderson and colleagues through the CanVector network, another Canadian study, did a randomized controlled trials of patients with suspected PE, and patients were randomized to a diagnostic algorithm of ventilation perfusion scan versus a CTPA. And you can see based on this trial that if patients underwent a diagnostic algorithm that was associated with CTPA, then there's 19% of folks that had PE diagnosed compared to 5%. So a difference between the two arms. You would expect that if these patients, if that, let's say 4% difference was statistically, 5% difference was clinically important, these patients, remember, were left untreated in the VQ scan arm. So you would expect a much higher rate of recurrent VTE in the VQ scan arm if these were clinically important. But really the difference we're seeing is 0.6%. And therefore that led to maybe, again, these clots, there's these additional clots diagnosed by the CTPA screening strategy or diagnostic strategy may not be as clinically relevant as one would hope. Now, the next question is, if they're increasing, is it because we're seeing more and more smaller clots? Is the increase in PE diagnosis associated with subsegmental pulmonary embolism? And before embarking into the study, we did a systematic review and meta-analysis of the literature, trying to look at what's the proportion of subsegmental PEs in the clinical studies that have assessed single detector CTPA versus multiple detector CTPA. And you can see that when you're just comparing single versus multiple, so between 1996 to, let's say, 2000, there is an increase in the proportion of SSPE that was diagnosed from about 5 to, let's say, 9%. And that seems to be consistent with the number of detectors. And you can see from that systematic review that if patient had increased up to 64% of, or 64 detectors, the proportion of SSPE was around 15%.
And that's what made us think as well that the study would be an easy one, right? Because we thought, well, if 15% of all the PEs we diagnose are subsegmental, then that study will take 6 months to
I think we said
right?
2 years.
Oh, we maybe said 2 years.
for inclusion. But you can see that it seemed to be an important problem, something that is common and for which that needed a study for. And more importantly, so we're assuming that the findings on the CT scans are real, right? But we did some work beforehand too, really looking at how reliable is an SSP diagnosis. And you can see that there's really a low inter-observer agreement between radiologists if it's in the real world like ER versus thoracic radiologist. And at the end of the day, at least back then, up to 50–60% of the diagnosis were probably false positive based on reinterpretation by an experienced radiologist. So at the time, we thought we're having a discussion about an increased risk of PE. We're not even sure if these are real, and we're not sure if they're clinically important or relevant. So SSP is not a new diagnosis, right? It's been there all the time. It's not because we have started using CTPA and that radiologist is actually putting in the impression there's a PE there. They've been there since, we've been starting practicing, or that we've been diagnosing SSP. So how did we do, or how did we manage SSP when we used VQ scan, or when you're still using VQ scan as the diagnostic modality for patients with suspected PE? Well, if you go back in time and you have a reflection about the PIOPED criteria for VQ scan, remember, for having a high probability VQ scan, you need 2 or more large mismatch defect in order to have a high probability scan. And if you have something that is not high or normal, if it's something that is non-diagnostic, intermediate, or low probability, studies that have compared VQ scan to pulmonary angiography have shown that 17% of patients with non-diagnostic VQ scan in PIOPED had isolated SSP on pulmonary angiography. And then what do you do based on pretest probability non-diagnostic VQ scan? Well, we do bilateral leg ultrasonography. And Dr. Clive Kieran and colleagues have shown us that bilateral leg ultrasound, serial bilateral leg ultrasound, is very safe. And if you don't have any deep vein thrombosis, then the underlying risk of having another deep vein thrombosis or recurrent event wouldn't be a recurrent, but a first event would be way less than 1% at 0.6% or so. And that's part of clinical practice guidelines. So it made sense at the time that if we felt like, well, if you have SSP on CTPA and you manage it like you would for a non-diagnostic VQ scan, then bilateral leg ultrasound and then repeating them, so doing them serially, should manage these patients without having a high risk of recurrent event down the road. So do we need to treat all these SSPEs? So this is just to show you that when we started, there was a lot of clinical equipoise about it. We just elected to show you two different things and some indirect data as well to support it. So this is a little bit of indirect data from our systematic review and meta-analysis. Remember, we said that the proportion of SSPE was increasing in the different studies when you increase the number of detectors. Well, if these were clinically important, you would argue that for patients that were left untreated, you would see an increased 3-month risk of VTE for those that were left untreated. And that's not something that we're seeing at all in that systematic review. So indirect evidence that maybe some of them may not be clinically important. And then two cohorts that we elected to show you, one from McMaster University, highlighting CanVector network work again, a cohort of 2,200 patients, 550 had PE, 82 had SSPE, and 50% did not receive anticoagulation therapy and did very well without any recurrent VTE, and some major bleeding complication in those that received anticoagulation regimen. That's not always the case. A post-hoc analysis from the Netherlands, combining two cohort studies, have shown that the risk of recurrence for patients that had subsegmental versus proximal PE while anticoagulated was similar, but there is a relatively small number of recurrent events, no bilateral leg ultrasound, some limitation. So we thought there was still some clinical equipoise in that particular matter. So because it was an important problem and we felt we could do this relatively quickly, we elected to do the SSPE study.
Thank you, Mark. Yeah, so, and really, as you say, right, I guess maybe we wouldn't do it that way these days, but the rationale was mostly a diagnostic rationale, right? We said, okay, we use not to diagnose these guys, not to treat them, or we knew that, you know, again, a non-diagnostic VQ scan with negative leg Dopplers was good enough at ruling out or deciding not to treat someone and at being safe at doing so. So that's really the mindset that we had. We were like, okay, eventually these should be considered as a non-diagnostic VQ scan, or this should be considered as not sufficient enough to decide on treatment. So and that explains a lot of our choice for the study design, because that, as you know, that's what we've been doing for diagnostic studies for the longest time, is let's apply our diagnostic algorithm. Let's see what the 3 months risk of VTE is, because we know from very old studies what the 3 months risk of developing a VTE is after having had a negative pulmonary angiography in patients with suspected PE, or after having had a negative phlebography for patients with suspected DVTs. And roughly these numbers are around 3%. So whenever you use a diagnostic algorithm to rule out PE or DVT, the way we validate them is that we apply them to consecutive patients with suspected VTE, and then we follow the ones who have no VTE at initial diagnosis. And if their 3 months risk of developing VTE is below 3%, we say, okay, that diagnostic algorithm is as safe as pulmonary angiography or phlebography were at ruling out the disease. So that's really what we had in mind. So we said, okay, let's do a study in which we will consider the same. We say, okay, the subsegmental PE, no DVT is considered negative, and let's hope that their risk of VTE at 3 months is below 3%. So we decided to include patients who is newly diagnosed SSPE. So obviously, initially it was very challenging, right? Because these patients were a patient with PE. So we certainly were very careful about selecting a rather low risk group of patients by, for example, excluding patients with active cancer, patients with a previous VTE, patients that would require oxygen to maintain an O2 sat above 92%, pregnant woman or patient who, well, for another reason, we also excluded patients with an indication for long-term anticoagulant therapy, is that we always do in diagnostic studies. It's just that obviously if someone needs long-term treatment, you prevent a new event to occur, so you falsely bias your study towards your hypothesis by reducing the chance of these patients to actually present a recurrent event during follow-up.
And patients, you know, the reason why these exclusion criteria is what it is, you need to remember that back in 2010, people thought we were a little crazy to do that, not to treat PE or starting not to treat PE. And, you know, I was asked, I remember presenting at an ISTH SSC meeting, and someone came to see me afterwards saying I was running a euthanasia type of study in Canada. Grégoire's patient, he was back in France. Patients were admitted to hospital for the SSPE, and then you include them not doing anything for them. So you can see that initially the people were not overly keen on participating, or they were a little bit lukewarm in participating because they were worried. And this, maybe I'll just put that here, but in 2016, that has changed completely because the ACCP decided it was fine not to treat them based on no additional data that what we've shown you. And that led to people being reluctant not to include them in SSPE, to people not even referring them anymore because they felt these SSPE, they were convinced now that these SSPEs were no longer clinically important.
Or people asking waivers saying, well, that patient is on long-term oxygen, but I'm not treating him anyway, right? Because so if you don't want him in the study, that's fine. But yeah, you're right. It changed quite dramatically.
So we're not conservative enough to too conservative within the study conduct.
Yeah. And likely, since we are at that, what the other big change during the course of the study as well is, I think, the diagnostic confidence, right? As you said, initially, a lot of these were likely false positive, but that actually likely changed over time, right? These days, when someone says there is a subsegmental PE, it's likely truly a PE, right? You've seen how with the number of detectors, not only the thickness of the slices decreased, but also the acquisition time, right? So back in 2000, you had a patient short of breath, you know, with query PE, and he had to be laying down flat on the scanner table, holding his breath for 25 or 30 seconds to acquire the images. So obviously you can see how you would have, you know, movement artifacts because they just couldn't do that, right? With the most modern technique, it's you know, it's instantaneous almost, right? It takes a second or two to get these images. So it's certainly even better than what it was back then. So what did we do? Well, exactly what we described, similar to what we would do with a non-diagnostic DQ, right? So at enrollment, all patients underwent the bilateral leg Dopplers. The ones who had a proximal DVT were treated with anticoagulants. Obviously, we had some patients who had either distal DVTs or superficial vein thrombosis, whose physicians decided to enroll anyway, because that's what we would do also in routine practice. But all the patients who had a first initial negative ultrasound did undergo another ultrasound 5 to 7 days later, same story. And that's actually when the follow-up period of the study started. So we started the chronometer after they had that second ultrasound that was negative and followed them up to day 90 of inclusion. Our primary outcome was the risk of recurrent VTE during follow-up. And these were symptomatic events, so there were no systematic screening test performed at the end of follow-up. All the events were blindly adjudicated by an adjudication committee. And we also collected as secondary outcome major bleedings during all the study period, as well as minor bleedings. In terms of statistical analysis, as I mentioned already, what we wanted to show was that initially, again, that diagnostic mindset. And actually, initially, people said, well, you're a bit too harsh with yourself. Like, maybe you shouldn't expect, 3%. Maybe you should be a bit more tolerant. But we still said, okay, likely our estimated rate of recurrence will be 1%. And including 300 patients would help us ensuring that the upper limit of the 95 confidence interval would be no higher than 3%. And again, because we were very concerned about safety, we also introduced a stopping rule in the study design by which if ever we had enough recurrent VTE that we would know that by the end of the study, the upper bound would be above 5%, the decision would be to stop the study. And we had a DSMB that was monitoring the study on a regular basis. And actually only 8 patients short of our total sample size, once we had included 292 patients, the DSMB, because we reached that stopping rule, asked us to stop inclusion in the study. And you know, yeah, go ahead, Matt.
I was just going to say there's 2 learning points here. The first is, I think Grégoire and I were stupid when we decided the sample size based on an estimate of 1%, right? Because we were so convinced at the time, based on the data from 2010, that these clots were not even probably real, that we said, well, it's like having a negative CTPA, but it was probably way too conservative. And if we would have been smarter, we should have probably developed it around a sample size that is, let's look at risk of recurrence for more proximal PEs, segmental or more proximal. What's the risk of recurrence for them on anticoagulation? Probably around 2-3%, depending on the studies. And that would have probably be a better way to recruit that. But things have changed over time.
Yeah.
And Grégoire highlighted that the DSMB, you know, the stopping rule was to make sure that not the first patients we included were going to be all dying from recurrent VTE, right? It wasn't to stop the study 8 short after 10 years. So these are things that we need to be mindful of for future studies, especially about stopping rules and interim analyses.
Yeah, it's interesting that, you know, when we were designing it, we were like, well, if out of the 21st patients, 7 or 8 have a recurrent event, yes, we should stop, right? But likely we should have put in there an adaptive, you know, something, or to say that that would be done only up to a certain number of patients or under a certain proportion of recruited patients. But anyway, didn't change much. All right. And so our primary analysis was a cumulative incidence of recurrent VTE during the 90-day follow-up periods. And we also had some pre-specified subgroup analysis based on the number of isolated subsegmental PEs, so whether the patient had a single subsegmental PE versus multiple subsegmental PEs, and also based on patient age. And we wanted to see whether patients, you know, older than 65 would have a higher or lower risk than patients younger than 65. So here is a study flow chart. And admittedly, right, again, we ran that for 10 years over several centers. So definitely, inclusion rate was much, much slower than what we had expected. Again, some worries at the beginning about including patients. At some point as well, in reality, maybe not even in the sites that we know very well, and colleagues that we know very well were saying, well, we really don't see them anymore, right? And as Mark was saying, after the guidelines change in 2016, we also heard or knew that, you know, some radiologists decided not to report them anymore just because I was saying, well, physicians don't treat these anyway. So anyway, a lot of factors, and it also shows, you know, over the course of 10 years, so many different things change, right? Anticoagulant therapy, diagnostic tests, and guidelines, making it very challenging to go through. So we assessed for eligibility 749 patients. A lot of them were not meeting inclusion criteria for various reasons. As you can see, not so many declined study participation at the end. A lot of patients were keen on doing the study when we were discussing that with them. And again, we ended including 292 patients. As you can see, 20 of them had anticoagulation initiated after they were diagnosed with a DVT, either on the initial ultrasound or on the repeated ultrasound a week later, and some of them for other reasons as well, AFib or anything else. So we end analyzing 266 patients, lost 2 of them to follow up, 6 of them withdrew consent during the course of the study as well. these are the baseline characteristics of the population. So I'll let you have a look. I would say slightly young-ish population as compared with a typical VTE study. As you can see, these were, because that's a question we're often asked, but obviously these were symptomatic patients, right? They were coming in with a suspected PE. We didn't enroll incidentally diagnosed subsegmental PE, so typical repartition of symptoms as well, with 60 to 70 patients with shortness of breath. Actually, a predominance of chest pain, which makes sense, right, as compared with other studies, maybe a few with hemoptysis, some of them with syncopal episodes, which surprisingly enough, we regularly see in patients with subsegmental PEs, likely because of pain or others. The majority of patients had a single subsegmental PE, and also we were excluding patients with active malignancy. 10% of them had a previous cancer. So this is the main slide, or the main results. So overall, the study was stopped after 8 patients presented with a recurrent event, and that corresponded to a cumulative incidence of 3.1%, with an upper limit of the 95 confidence intervals up to 6.1%. A common question is, were these PEs, were these DVTs? Well, so 4 of each. So 4 patients came with a recurrent proximal PE, and 4 of them presented during follow-up with a proximal DVT. Importantly, there were no fatal events during the study. We did also have 2 major bleedings corresponding to a major bleeding rate of 0.7%. Remember that these patients were not treated on anticoagulant. One of these events was fatal. It was a fatal hemoptysis in someone with aspergillosis. And we know from other studies, right, that it doesn't take anticoagulant therapy to have a major bleed. Even if you're not treated with anticoagulant, you can still get a major bleeding for sure. Some had minor bleedings, and we had 4 deaths in the study, 2 from cancer, 1 from sepsis, and that 1 from major bleeding. This is a survival curve. That was also interesting to us, because we were, again, it doesn't seem, well, you can obviously it's a limited curve, right? Limited number of patients, limited number of events, but it doesn't seem that you're paying the price upfront, which is what you could have expected as well, right? That most of the recurrent events would be very early on, but it looks like they were rather spread over the 3 months of the follow-up period. And we actually did a monthly incidence of recurrent event, which was 1% per month, pretty much during the entire course of the study. So group analysis indicating that and no statistical significance here anywhere, but still it seems that the risk of having a recurrent event is higher when patients come in or were included after multiple subsegmental PEs as compared with a single subsegmental PE. And similarly, that older patients have a higher risk of recurrent events than patients below the age of 65. So limitations, well, I think we mentioned a lot of them already, right? But definitely an important one is that we did not include patients with high-risk feature. So that 3% overall risk really applies to rather low-risk population. We didn't have central adjudication of SSPE because we wanted the study to be pragmatic, but that's certainly something that we are planning at looking at and at seeing whether it makes a difference or not. And so we followed the patient only for 3 months. So a common question is, what happens next? What's their long-term risk of recurrent VTE? Or also the potential concern of these patients potentially developing CTEPH over time, but we're not able to address that either. So I take this opportunity to thank all the ones, and I'm sure that most of the names here are in the audience today. So thank you very much to all of you. I think, we know it took a lot of courage initially, and it took a lot of perseverance to include these patients and to run the study. So thank you very much. And that's a study that really shows again the strength of what we've been developing in the meantime, where, when we started, it was vector, right? And then we did CanVector, and in France, Innovti, and then we had Invent, and then we could add the Dutch network to it. So I think really shows the value of working together with networks and with international networks as well. And a word of thanks to our funders as well, including the Heart and Stroke Foundation in Canada. So back to Mac, or in tandem to discuss a bit, what do we do with that now, right? Where do we go? What do we change practice, and how do we handle that clinically? And which perspective, where do we go next?
Yeah, and it's hard because the SSP study provides us with a risk of recurrence off anticoagulation, but doesn't give you the full picture with the balance of the underlying risk of VTE and the risk of bleeding on anticoagulation. And I think the ACCP in 2016 and 2021, I've put the reference from Clive here, but Lisa Moore has the most recent version in 2021 too, but it's available online but not yet published. But it hasn't changed, and what they're saying is, do your risk benefit assessment and make a decision. So for a low risk of recurrent VTE, then maybe clinical surveillance is reasonable, and for a high risk, then maybe anticoagulation should be desirable, both with grade 2C, which more or less provides you with insight that there's very little data to help. And I would hate to think that the fact that we found more recurrent VT than what we're expecting means for clinicians that they need to treat all these clots, because I've just finished 4 days of service. We actually had many patients with SSP, both at our general campus here and the civic campus, all of which were fully anticoagulated, and at least 2 of them had major bleeding complications from anticoagulation. So I think we need to be mindful that what we're trying to do with SSP, especially if there's no lower extremity VTEs, superficial, deep, proximal, distal, is you're probably trying to prevent a recurrence, right? You're probably not overly worried about the initial clot. You want to prevent a recurrence. So maybe tailoring anticoagulation may be desirable in some patients. So I think the ACCP recommendation still stands. It's probably important to have a look with an experienced radiologist to confirm the diagnosis, although probably less of a concern these days, but still, if there's breeding artifacts, or if there's all sorts of different reasons why you could have artifacts on the CTPA, so that's important to review. And if your patient seemed to be at low risk of bleeding and maybe at high risk of bleeding too, if there's good cardiopulmonary reserve, then maybe it'd be reasonable at that time to decide not to anticoagulate or provide prophylactic dose or intermediate doses. The risk-benefit ratio needs to be done on a case-by-case basis. But as Grégoire mentioned, an SSP diagnosis on its own, you can't really make a decision unless you decide to treat them. But I think if you're contemplating not treating them, you need to do bilateral leg ultrasound. You actually need to do serial bilateral leg ultrasound, because clots were found at the time of diagnosis, not the usual 40% or 50% that we would see. It was 9%, but still, 1 in 10 patients will have an underlying diagnosis of DVT. It's an indication for anticoagulation, but we also found clots on the serial ultrasound. So making a serial ultrasound would be desirable if you decide to do clinical surveillance for sure. So if we go back to Miss MT, I would argue it'll depend on your risk-benefit ratio. So she seemed to be at low risk of recurrence. She seemed to be at low risk of bleeding too, but depends on other features.
Single event, below 65.
Yeah. So these are things that you need to consider after discussion with the patient, of course. We highlighted that it would probably be reasonable to do bilateral leg ultrasound and serial ones and no DVT, conservative measures, but it's also probably reasonable to treat her. We didn't highlight the low microrate heparin plus warfarin. Obviously would be an option, but she didn't have any other contraindications, so it seemed to be easier and to use a direct anticoagulant in that particular setting. So again, the risk-benefit ratio is still a little bit unclear, because we don't necessarily have a good assessment of the bleeding side of things. So there's no doubt that SSPs are frequent in patients with suspected PE. You see them all the time. If they don't have a proximal DVT, the risk of recurrence is relatively low, but higher than what we were planning to be. So we need to be mindful of that. These can cause trouble. So it's important to have a good risk-benefit ratio. And maybe if the patient has a period of time where they're really high risk of bleeding, maybe there's not that much advantage or benefit to push anticoagulation. But if they're low risk of bleeding, then maybe anticoagulation would be the safest thing to do as well. There's a couple of randomized controlled trials ongoing, one in the UK, one in Switzerland. I've put the SAFE SSPE trial here because a number of CAN vector network sites will be participating into, where patients with subsegmental PE and no lower extremity DVT are randomized to rivaroxaban at the PE DVT dosing or placebo and then followed over time. So this will provide us with the risk-benefit ratio in order to make the right treatment decision for these patients, I think.
We wish them more luck than what we had.
Yes, but they're having a hard time recruiting. I told them so. So this is all we had, and then hopefully we can open up the discussion. There's 15 minutes left. If there's no question, then that's fine. If there are questions, then we'll be happy to entertain them.
There are questions. Thank you for your excellent presentation. I think it went very well. So we have comments and questions. Maybe I will start with the questions, and if we have time for the comments later. Overall, everybody's happy with your presentation. It was an excellent presentation. And so here are the first questions I have. So of the DVTs diagnosed on routine ultrasound, how many were the first one compared to the second one? So that's Dr. Peter Gross who's asking the question. So do you have this information?
We do. Grégoire should remember because he has a photographic memory.
I think it was 14 versus 6.
Yeah, 14.6, but I'm just opening up the article to confirm, but I think it's 14.6.
But certainly the second one is not non-negligible.
Yes.
Right?
Yes, okay, and which make me think, what if you do a first ultrasound assessment that doesn't find a proximal DVT, and then the second one shows a distal DVT? How would you manage this?
As part of the study, so that was left to the discretion of the treating physician.
What would you do now?
Another one?
Another one.
No, it's a good question already. So I think we actually looked at this specifically. So only one of the recurrence had a formal distal deep vein thrombosis. So if you look at the odds, it increases the odds importantly, but it's still just one event. So it's hard to put that into perspective a little bit. I probably would be a bit more conservative, and if there's anything in the lower extremities, I would tend to treat them until we have more data to provide risk-benefit ratio, I think. But but admittedly, if the patient's at high risk of bleeding, then serial ultrasound would probably be reasonable in the short term.
Mm-hmm. So the next question, 2 patients died of cancer, even though patients with known cancer were excluded. Were these patients also the ones with recurrent VTE?
One of them definitely yes, because I remember that that's a patient that was actually admitted for a bleeding, ended being diagnosed with bladder cancer and was discharged and then got an event. And the other one, I can't tell you.
No. Just one of them, yes. So these are cancer diagnoses beyond enrollment. So they had the SSPE during the follow-up. They were diagnosed with a cancer afterwards.
Now that you have the results of this management study, would you say that these patients who were subsequently diagnosed with cancer should be considered for preventive anticoagulation?
Yes.
Yeah, I think so. Yeah, because again, we excluded cancer patients from the study, right? So if someone later is diagnosed later with cancer, yeah, I would, yeah.
And how long after? Like within 3 months, within 6 months?
Yeah, that's
yeah. tricky. Yeah. I mean, should be considered and assessed probably. Yeah. So our next question from Dr. Linkins. Did you repeat inter-observer agreement assessment of your CTs?
Yeah, no, we didn't yet, but
Not
that's certainly the plan. We will do all that, like, because we wanted it to be pragmatic, so we let investigators make a final decision on diagnosis locally, but we have been collecting all the images, so we'll be able to do that, like IOR and also expert review and see how these play out in terms of outcomes.
Mm-hmm. So I'm sorry, because questions keep coming, so it may not make sense, but so the next one is, so for cancer patients, let's say you have a cancer, I imagine that the question is, if you have a patient with cancer-associated subsegmental PE, would you treat? And for how long would you treat?
Yeah, I think so. Most clinical practice guidelines would recommend treatment of incidental SSP in the setting of cancer. As we mentioned during the presentation, you're probably not overly worried about this particular clot, but clearly the patient is hypercoagulable. And there's data suggesting that patients that have previous history of VTE, when initiating chemotherapy, for example, that's the equivalent of coronary score of 3 or more. So their underlying risk of recurrence is much higher. So I think they deserve at least some form of thromboprophylaxis. Should they be on therapeutic dosing, then I think it depends on the underlying risk of bleeding. If they're low risk bleeding, why not? And then, you know, continuing anticoagulation in the same way, but probably at a prophylactic level for secondary prevention. And then, just for Peter's, we didn't remember this, right? Your photographic memory is
wrong.
Getting old.
I'm getting old.
The 6 and 14 was proximal versus distal.
Oh, okay.
So I'll have to have a look at the database and we'll get back to Peter.
Okay. But for sure, I think these are key messages. And several times when we were doing the study, we're like, ooh, lucky us to have done the serial. And actually, yeah, and further to that, because that could be a question as well, is that in Europe, initially we said, because we were doing in Europe a lot of whole leg ultrasound, right? And initially I thought, well, okay, you know, if you decide to go for a whole leg, then you don't need a serial. But eventually we had, well, not so many, but we had several DVTs diagnosed on the serial, up to the point that we ended amending the study in Europe, saying you should rather get that 1 week ultrasound as well.
Yeah. And so to go back on the previous question, you know, cancer-associated SSPEs. So you answer for asymptomatic as well, you know, the incidental SSPEs that are diagnosed in cancer. Would you recommend the same, you know, so to treat if it is a non-cancer associated SSPE?
So should we treat or not the SSPE in
incidental SSPE, not in the cancer of not in the setting of cancer?
Right. Well, yeah, who knows, right? So there's in the setting of cancer, the incidental findings outside of cancer is very rare, but it happens. But if you extrapolate data from the cancer studies, we know incidentally detected VTEs tend to recur less than those that are symptomatic. So if you extrapolate, it may be correct or not to do that, but if you extrapolate that, let's say the patient had COPD, underwent CT, and you have an incidental SSPE, should they be treated or not? Then I would probably use the same algorithm than what we just discussed. And have the same discussion about risk-benefit ratio. May they be at a lower risk of recurrence than what we just showed you, because these are all symptomatic event? It's quite possible if you look at other patient population, but we don't know that for sure. So I would probably use the same things for now. Is that answering the question, Will?
I think it does, yes. Another question from Dr. Castellucci. So how long would you treat SSPE, unprovoked SSPE? 3 months, 6 months?
Yeah. And this is purely anecdotal, right? I don't tend to treat them long term. They were not included in reverse, for example, or the other studies looking at secondary prevention. You could have a debate that these don't necessarily need to be treated to begin with. So unless there's formal underlying risk factors that will lead to higher risk of recurrence, I tend to treat them for 3 months, then I stop. But I'm not sure if
that's fair. Yeah, mostly I would do that as well. A bit like, you know, whatever that means, a bit like a distal DVT, like you think of it the same way, right? Whether that's right or wrong.
So remember, although it's 3% risk of recurrence off treatment, this is similar to the VKA studies of more proximal PEs. So their risk of recurrence is for sure smaller like it is for distal DVT. We don't know yet, you know, that's another knowledge gap, what's their long-term risk of VT, but it can't be, you would assume it can't be that high. And even for proximal lower limb and proximal PEs, the risk benefit ratio for lifelong anticoagulation is already tight. So I can't think that it would not tip towards you stop for and not long-term anticoagulation. But it's purely anecdotal.
Okay, there's a lot of questions coming in. So, and I'm sorry because I'm not sure that we'll have the time to answer all questions and to read all the comments. So, congratulations from Dr. Khan, and she's asking for next iteration of VT treatment guidelines. What is your prediction regarding the guideline for management of SSPE?
Well, if you look, it's funny, right?
And strength of recommendation. So direction and strength of recommendation.
Well, if you look at, so, you know, when we published, we were very straightened by the book, right? You know, the study failed to meet its initial target, blah, blah, blah. And then we got two very contrasted
or polarized,
polarized answers, right? One group sent a correspondence saying, well, don't say the story is over. There is certainly room for discussion in this patient, for more studies, and equipoise is still there, and so on. And other answers being very concerned and saying, well, clearly the study shouldn't even have been done, and all these patients would be treated, right? So there is obviously equipoise is still alive, right? So I don't know where the guidelines will be, like whether they will.
Yeah, I would like to see the guidelines where the ACCP is landing and provide some guidance on how to make the management, because you know, bleeding or hemorrhagic complication is real, especially for admitted patients and other high-risk patients. But I think as clinicians, we always feel more comfortable with errors of commission and omission. And if someone bleeds, then that's not my problem, it's the blood thinner's fault. Although it's not the right rationale, we all agree on that. But I think as clinicians, we tend to put more emphasis on that. So I'm assuming until SAFE SSPE, I'm assuming they'll probably give me a weak recommendation for treatment, unless they're participating into a clinical study. But that's just a prediction.
Yeah.
But hopefully not. Hopefully they'll be strong.
Yeah.
At least we have a number, right? Because, you know, I see another question about how does it change practice, you know, and we used to have it was a complex discussion to have, right? So now I feel that, you know, we have a number to give patients, and it helps quite a lot, I feel.
Yeah, for shared decision. Yeah, absolutely.
Yeah, and then, you know, sometimes you have these patients, like when I was on service, they have SSP, fair enough, you treat them with anticoagulation. They don't have lower extremity ultrasound, they have a major bleeding complication, and I don't lose sleep about not anticoagulating them for a while, right? Because their underlying risk is probably very small.
I think we have time for one last question. You will have less than a minute to answer. Would you APS testing or cancer screening in these patients?
I don't think I would.
I don't think I would either. The underlying risk of recurrence is relatively small from an APS testing point of view. So unless I would have suspicion, the cancer screening point is interesting, because we found there is some cancer diagnosed during follow-up, probably led to maybe a higher risk of recurrence a little bit, at least one event. Maybe we would have completed the study otherwise. But again, we know cancer screening in more proximal clots is extensive screening for a time being is not recommended until we have the SOM2 and VICTEP2 study. So I would make sure they're up to date with age and gender screening as they should be, with or without clots, but not more than that.
And we'll look in more details, but I don't think we even had 5% of cancer in the study, right? So what we didn't have a year of follow-up either, but most of the cancer are diagnosed very early on, and we didn't see that many.
Thank you both. I'm sorry for all the questions we couldn't answer today. I'm sure that you can be available by email if anyone has some more questions. So stay tuned for our next seminars, and it's going to happen on February 7th. And have a good afternoon, everyone. Bye.
Thank you, everyone. Thank you very much for attending.